Hello everyone and welcome to our module on hyperlipidemia. There are four standard measurements that are used to assess the lipid status of a patient. They are the total cholesterol, the LDL, the HDL, and the triglycerides. LDL is called the bad cholesterol. The way I always remember this is the L is for lousy. And the reason it's called the bad cholesterol or the lousy cholesterol is because higher levels of LDL cholesterol are associated with greater risk for cardiovascular disease, things like stroke and myocardial infarction. Less than 100 is a very good level for LDL cholesterol. Greater than 200 is a very high level for LDL cholesterol. And importantly, there's lots of evidence that treating high levels reduces the risk of cardiovascular disease. So if you take care of patients who have high LDL and you recommend lifestyle interventions or drug therapy that reduces the LDL cholesterol, we also know from lots of clinical trial evidence that that lowers their risk of cardiovascular disease like strokes and heart attacks. HDL cholesterol is the good cholesterol, and I've always remembered this as the H is for healthy. And the reason it's called the good or healthy cholesterol is because it's inversely associated with risk. So the higher your HDL cholesterol, the lower your risk of cardiovascular disease. And less than 45 is considered low. Numbers higher than 45 are considered good. And the big distinction here between HDL and LDL is we really don't have much evidence that raising low levels reduces the risk. So if you're treating a patient and their level of HDL cholesterol is low, that means they're at greater risk. But if you ask them to do interventions that raise their HDL, it's not clear that those interventions modify their risk, and that makes HDL very different from LDL. And then the final element of the lipid evaluation is measurement of serum triglycerides. A normal triglyceride level is under about 150. And the bad thing about triglycerides is if they get really high, like over 800 or over 1,000, they can cause pancreatitis. And really the main reason that we treat high triglycerides is to avoid pancreatitis. Elevated triglyceride levels are only modestly associated with coronary disease, and there really isn't any good evidence that lowering triglyceride levels reduces the risk of coronary disease. So mainly when you're taking care of a patient and the triglycerides are high, the reason you're going to treat that patient is to prevent pancreatitis. There's not much evidence that treating high triglycerides reduces the risk of cardiovascular disease. So when we say that a patient has hyperlipidemia, we mean that they have elevated total cholesterol, LDL cholesterol, or triglycerides. And remember, LDL is the big one. If that level is high, their risk is high. And the reason hyperlipidemia is bad, as we've already mentioned, is because it's a risk factor for cardiovascular disease like coronary disease and stroke. Another reason it's important is because it's modifiable. Often patients who have hyperlipidemia have it because of lifestyle factors. Patients who lead sedentary lifestyles and don't exercise, patients who eat lots of saturated and trans fatty acid foods, and patients who don't take in enough fiber can all develop hyperlipidemia, and therefore if they modify these lifestyle factors, you can lower their cholesterol and lower their risk. Most patients who have hyperlipidemia have primary hyperlipidemia, meaning they do not have another disorder that is causing the lipids to be high. But there are some causes of secondary hyperlipidemia, and you should be aware of these especially for your boards. Patients who consume lots of alcohol can develop hyperlipidemia. Hyperlipidemia is normal in pregnancy because it provides more lipids for the baby. Beta blockers and thiazide diuretics like hydrochlorothiazide can increase the lipid levels. Patients who have thyroid disease often have abnormal lipid levels. And then finally, hyperlipidemia is one of the elements of the nephrotic syndrome. The initial treatment for hyperlipidemia is always lifestyle modification. This should be recommended to all patients. This includes eating a healthy diet, weight loss and exercise, and quitting smoking. After you recommend lifestyle modification, the next major clinical decision you have to make when treating a patient with hyperlipidemia is whether or not to prescribe a statin drug. We'll talk later about how statin drugs work, but for now just know that they are the most effective treatment we have for hyperlipidemia, and there's lots of evidence that statins reduce the risk of cardiovascular disease. So when you're faced with a patient with hyperlipidemia, the major decision you have to make is whether or not that patient should be placed on a statin in addition to lifestyle modification, which you recommend to all patients. So we'll talk about how you decide whether or not to prescribe a statin to a particular patient in a minute, but first I want to let you know that the guidelines recommend two different types of statin therapy. The first type of statin therapy is called moderate intensity therapy. The second type is called high intensity therapy. And as we'll see in a minute, some patients need moderate intensity and some patients need high intensity. There are lots of choices for moderate intensity statin therapy. These include atorvastatin 10 to 20 a day, rosuvastatin 5 to 10 a day, or simvastatin 20 to 40 a day, but there are other options. For high intensity statins, there are only two choices. The first one is atorvastatin 40 to 80 per day, and 80 is the max dose of atorvastatin. Second option is rosuvastatin, 20 to 40 a day, and 40 is the max dose of rosuvastatin. So now that we understand what the options are in terms of moderate intensity statin therapy and high intensity statin therapy, let's talk about how you decide who deserves treatment. And one thing that can be confusing about hyperlipidemia is deciding whether or not to treat a patient depends on more than just the cholesterol level. Many patients need to be on statin therapy no matter their cholesterol level because they have such high risk of cardiovascular disease. So for example, patients who have a history of coronary disease, stroke, or peripheral arterial disease like claudication or carotid artery disease, these patients should all be on a high-intensity statin no matter their cholesterol level. They're at such high risk that they merit statin therapy no matter what their cholesterol is. Similarly, diabetics who are more than 40 years old need to be on a moderate or high-intensity statin no matter what their cholesterol level is. That's because their risk of vascular disease is very high. For patients who don't have one of these comorbidities or diabetes, if their LDL cholesterol is greater than 190, then they need to be on a high-intensity statin. 190 is a very high level of LDL, and patients with that level of cholesterol elevation need statin therapy. Now, most patients you treat won't be in one of these first three categories here. So for all of those patients, what you're going to do is use a standard guideline recommended calculator called the ASCVD risk calculator to determine the patient's risk of cardiovascular disease over the next 10 years. And if that risk is greater than 7.5%, then that patient should be treated with a moderate or high intensity statin. If the risk is less than 7.5%, then they don't need statin therapy. So you can find these calculators online by just searching for them. You enter the patient's age, gender, and race. You enter their total cholesterol, HDL cholesterol, systolic and diastolic blood pressure. And then you also need to indicate whether they are treated for high blood pressure, diabetes, and whether or not they are a smoker. Once you do this, the calculator will use clinical trial data to determine the 10-year risk of heart disease or stroke. If the number is more than 7.5%, then that patient should be placed on a statin. If it's less than 7.5%, like this person here, then that patient does not need to be placed on a statin. Once you decide to treat a patient with a statin, if they have one of those four indications I showed you on the table 2 slides ago, the treatment goal is usually to get the LDL cholesterol under 100 milligrams per deciliter. And for patients who have known vascular disease, like coronary disease or stroke, the goal is often less than 70 milligrams per deciliter based on a couple of trials which showed that getting it down to this level improved outcomes. Now we'll talk about signs of hyperlipidemia, and the first thing you should know is that on physical exam, most patients have no signs or symptoms. Hyperlipidemia is generally considered one of the silent killers, and the only way you can identify it is by screening patients with blood tests. There are some physical findings that occur in patients who have very, very high lipids, and these patients usually have some type of genetic familial syndrome that causes their cholesterol to be very, very high. So some of the physical exam signs of hyperlipidemia when the lipid level is very, very high are shown in this slide. Xanthomas are plaques of cells filled with lipids. They look like skin bumps, or they can also appear on the eyelids. In the bottom right corner here is a picture of someone who has some xanthomas on their eyelids. A tendinous xanthoma is a xanthoma that occurs on the tendons. These are very common on the Achilles tendon. And this is a picture of a child who has a tendinous xanthoma here. And then finally, a corneal arcus is a lipid deposit in the cornea. It looks like a ring around the iris. If you look at this picture in the middle of the screen on the right, there's this white ring around the iris. That is a corneal arcus. So now let's talk about the familial dyslipidemias. These are all inherited conditions that run in families. They're caused by a genetic mutation in one of the genes that's related to processing of lipids in the body. There are 4 of them that you should know. Type 1 and Type 3 are autosomal recessive. Type 2 and Type 4 are autosomal dominant. And in the next few slides, we'll go through all 4 of them and talk about the clinical features. Really, for your board exams, all you need to do is be able to recognize one of these syndromes and name it. Type 1 dyslipidemia is also called hyperchylomicronemia, and chylomicrons are what carry triglycerides from the gut to the liver. So patients who have elevated levels of chylomicrons will have very high triglycerides. People who have this disorder can have triglycerides over 1,000. Their plasma can appear milky from all the triglycerides in the plasma. This is caused by some deficiency or dysfunction of the enzyme lipoprotein lipase. And the main problem that people have with this disorder is recurrent pancreatitis. As I told you earlier, very high triglycerides lead to pancreatitis. They can also have an enlarged liver from buildup of triglycerides, and they can develop the xanthomas we saw a few slides ago. And the mainstay of treatment for patients with this condition is a very low-fat diet. Because chylomicrons carry triglycerides from the gut to the liver, if you don't eat much triglycerides, then you won't have much of a problem. Patients can have a normal lifespan if they eat a low-fat diet, And there doesn't appear to be a high risk of atherosclerosis among people who have this condition. Remember what I told you before. Triglycerides are only very weakly associated with atherosclerosis. The main problem with high triglycerides is pancreatitis. Type 2 dyslipidemia is called familial hypercholesterolemia. This is a condition I sometimes see in my practice because these patients get very early coronary disease. It's autosomal dominant, and depending on the severity of the condition, patients with this problem have few or zero LDL receptors in their liver, so they don't pull LDL from the plasma into the liver. This leads to very high LDL levels. Patients who are heterozygous for a gene mutation for this disorder can have an LDL over 300. Homozygotes can have a level over 700. When the level gets very high, they can develop tendinous xanthomas, they can develop corneal arcus as we saw, but once again, the main problem is severe atherosclerosis. Patients with this condition sometimes present with myocardial infarctions in their 20s, much earlier than people would otherwise. Type 3 dyslipidemia is called familial dysbeta-lipoproteinemia. This is caused by mutations of the apolipoprotein E gene. And when a mutation is present in copies of this gene, lipids are poorly cleared by the liver. And what accumulates in the plasma when patients have this disorder are chylomicron remnants and VLDLs, which are collectively known as beta-lipoproteins. Therefore, this disorder is called dysbeta-lipoproteinemia. Patients with this condition have elevated total cholesterol and triglycerides. That's how you're going to recognize it in a board question. If they just have very high triglycerides, it's going to be a type 1. If they have elevated total cholesterol and triglycerides, it's probably a type 3. Usually this is mild. The total cholesterol elevation is only greater than about 300. These patients can get xanthomas, and because the total cholesterol, not just the triglycerides, are elevated, these patients can also develop premature coronary disease. And then finally, type 4 dyslipidemia is called hypertriglyceridemia. This is an autosomal dominant condition, and the problem here is that patients with this disorder have overproduction of VLDL by the liver and also impaired breakdown of VLDL. This leads to a modest elevation in triglycerides, not as high as patients who have type 1 dyslipidemia. Usually the triglycerides are in the 200 to 500 range. In terms of particles, there's an increase in the VLDL particles. And the important thing to always remember about this type of dyslipidemia is it's usually associated with diabetes type 2 and sometimes even hypertension. So basically, this is going to be a patient who has several risk factors for coronary disease like diabetes and hypertension, and on routine screening blood work, the triglycerides are elevated. That patient may have this form of dyslipidemia. And this is associated with some increased risk of coronary disease and premature coronary disease, most likely because many patients with this disorder have things like diabetes and hypertension. And also, patients with this disorder sometimes have a low HDL, so that contributes to a higher risk of vascular disease. For the remainder of this video, I'll talk about therapies that can be used to lower the lipids. We'll go through all the therapies shown in this slide. Remember, statins are the most important and the most widely used. That's because they're very effective in lowering the LDL, they can raise the HDL, and also they have lots of good data showing that they reduce the risk of vascular disease. So let's talk about the statins. These drugs are called statins because their name ends in statin, drugs like lovastatin, atorvastatin, and simvastatin. And the way these drugs work is by inhibiting a liver enzyme called HMG-CoA reductase. This enzyme takes this large molecule shown at the top of the screen and converts it into mevalonate, which can go on to form cholesterol. So when you inhibit this enzyme with a statin drug, there's less cholesterol synthesis in the liver. And when the liver can't make enough cholesterol, what it does is it puts LDL receptors on the surface of hepatocytes to try and make up for the cholesterol it can't synthesize by pulling cholesterol from the plasma. So once you give a statin, there will be more LDL receptors on hepatocytes, and that will lead to the major effect of these drugs, which is a drop in the serum LDL level. There's also some decrease in triglycerides and some increase in HDL, but the major effect is to decrease the LDL level. And the reason these drugs are so popular is because there are lots of clinical trials showing excellent outcomes data, meaning that these drugs not only lower the LDL level, but they also decrease the risk of myocardial infarction and death. Most patients taking statins have no side effects, but there are adverse effects in a minority of patients. There can be hepatotoxicity with a rise in the serum AST and ALT. And then finally, one of the most common side effects of statins are the muscle problems, and we'll talk about those now. So statins can cause lots of different types of muscle problems. The most common muscle problem associated with statin use is myalgias. Patients will complain of weakness and soreness, but if you measure the serum CK level to look for evidence of muscle damage, it will be normal. And this unfortunately causes a number of people to stop taking these drugs. Less common but more serious is myositis. Myositis is inflammation of muscle tissue. The symptoms are similar to myalgias, but the CK level will be increased in the serum. And then very rare, but much more serious, is rhabdomyolysis. This has been associated with statin therapy in a very small minority of patients. These patients develop all the classic features of rhabdomyolysis: muscle weakness, muscle pain, dark urine from myoglobin spilling into the plasma and the urine. The CK levels can get very high in the serum, as high as 1,000 or more, and the myoglobin can cause acute renal failure and even death. Now, rhabdomyolysis rarely occurs just from taking a statin. It usually occurs when someone takes a statin together with another drug that leads to rhabdomyolysis. So, for example, gemfibrozil is a lipid-lowering drug we'll talk about later, and it's associated with rhabdomyolysis. So patients that take gemfibrozil together with a statin can develop rhabdomyolysis. And then many statins are metabolized by the liver P450 system. So if patients take a statin drug together with a P450 inhibitor, that can raise the level of the statin drugs in the plasma, and that can lead to rhabdomyolysis. So most but not all statins are metabolized by the liver P450 system. Atorvastatin, simvastatin, and lovastatin are the three commonly used statins that are metabolized by the liver P450 system. Ravastatin and rosuvastatin are exceptions. These two drugs are not metabolized by the P450 system and do not have interactions with other P450 drugs. But for statins that are metabolized by the P450 system, they can interact with other drugs. In particular, if a patient takes a P450 inhibitor together with a statin, this can raise the serum levels of the statin drug and increase the risk of liver damage or of muscle problems like myalgias. I've listed a couple of P450 inhibitors here on this slide. Cyclosporin, I have unfortunately seen cause rhabdomyolysis in a patient when given together with atorvastatin because of this interaction. Macrolide antibiotics inhibit the P450 system, so do azole antifungal agents, and so do HIV protease inhibitors. So patients who take any of these drugs together with a statin may develop a serious complication like liver failure or rhabdomyolysis. And then finally, grapefruit juice is a famous inhibitor of the P450 enzyme system. So if you have a patient on a statin who drinks lots of grapefruit juice, they can potentially develop statin problems associated with this. Next, let's talk about niacin. Niacin is a vitamin. It's vitamin B3. It's found in many foods. If you look at the labels of foods, you will often find niacin listed, like shown on the screen here. And niacin can be used in the treatment of hyperlipidemia by administering high dosages as a supplement. Its mechanism of action is complex and poorly understood, but the overall effect if you take large quantities of niacin is that the LDL level will fall and the HDL level will go up. This is believed to occur because niacin inhibits the breakdown of HDL. And I've bolded the HDL increase here because that's the main time we use niacin. It's usually used in patients who have a low HDL and we want to make it higher. There's not a lot of evidence that this will reduce the rate of myocardial infarction and stroke, but in some patients with very low HDL, niacin can be used. The major side effect of niacin is flushing. Patients who take this drug will tell you that about 30 minutes later, their face turns red and becomes warm, and if they look in the mirror, it can sometimes be bright red, which can be embarrassing. This is because niacin in high dosages stimulates the release of prostaglandins in the skin, which leads to vasodilation. For this reason, you can blunt this side effect by taking an aspirin, which inhibits prostaglandin synthesis, about 30 minutes or so before taking niacin. Importantly, this effect fades with time, so what you need to tell your patients if they're going to be on niacin is to try and keep taking the niacin, and after a few weeks, usually the flushing becomes less severe or goes away altogether. Niacin can also raise the serum glucose, and it can raise the uric acid level, so it may potentially cause insulin resistance through a poorly understood mechanism, and this drug is usually avoided in patients with poorly controlled diabetes. It also can raise the uric acid level, so it can precipitate a gout attack like this person has here with this swollen big toe. Moving on, let's talk about fibrates. These drugs are called fibrates because they are derivatives of fibric acid. Drugs in this class include gemfibrozil, clofibrate, bezafibrate, and fenofibrate. Fenofibrate and gemfibrozil are the two members of this class you'll most commonly see used clinically. The way these drugs work is by activating PPAR-A, which is a modifier of gene transcription in the liver. When PPAR-A is activated, there's more lipoprotein lipase activity, and this leads to the liver breaking down more fatty acids. The major overall effect of this is that more triglycerides are going to be broken down, and that means that the major use of this drug is going to be for patients with very high triglycerides. It's the main time when we use fibrates is patients who have hypertriglyceridemia. Side effects of these drugs are somewhat similar to the statins. They can cause muscle problems like myositis and even rhabdomyolysis. In particular, rhabdomyolysis is associated with gemfibrozil, so if a patient is going to be on a statin and a fibrate together, gemfibrozil is usually not used and instead fenofibrate is used. And in general, you have to be careful when you're giving patients fibrates and statins together. These drugs can also raise the LFTs, and they can also disrupt cholesterol metabolism in general, and when you do that, that can cause cholesterol gallstones to precipitate in the gallbladder, leading to gallstone disease. Next, we'll talk about the cholesterol absorption blockers. There's only one drug used clinically in this class, that's ezetimibe. It blocks cholesterol absorption at the intestinal brush border. As a result, dietary cholesterol will not be absorbed as well among patients taking this drug. It's highly selective for cholesterol, so it doesn't affect fat-soluble vitamins and triglycerides. It just affects the absorption of cholesterol. When you absorb less cholesterol from the gut, the liver will find that it doesn't have enough cholesterol around to work with, and it will increase the number of LDL receptors on the surface of hepatocytes. This is the same thing that happens when patients take statins, and this results in LDL cholesterol particles being pulled from the serum. The result is a modest reduction in serum LDL by ezetimibe, not as much as with statins, but some reduction in serum LDL. There's also some decrease in triglycerides and some increase in HDL. The main reason we don't use this drug very much is because there is relatively weak data on hard outcomes like reduction in MI and death. Statins have much more robust data showing that they lower the risk of myocardial infarction or death. These drugs have an effect on the liver, so they can raise the LFTs, but really their main side effect is diarrhea. Because they interrupt absorption in the gut, that can lead to diarrhea. Bile acid resins are very old hypercholesterolemia drugs. They're really only of historical interest. Very few people use them in the modern era. Drugs in this class include cholestyramine, cholestyramine, and cholesevelam. These prevent the intestinal reabsorption of bile. So you may remember that the liver synthesizes cholesterol, which goes out in the bile. It enters the GI tract, and then it is reabsorbed. These drugs block the reabsorption. As a result, more bile is excreted in the stool, and the liver will make more cholesterol to make up for the loss of bile, and this can lead to some lowering of the LDL. The problem with these drugs is they cause bloating and a bad taste, and patients find them miserable. They often have lots of stomach upset and lots of gas. In addition, they can disrupt the absorption of certain fat-soluble vitamins, so that's a problem. And then finally, by disrupting the absorption of bile, they can lead to gallstones in the gallbladder. Omega-3 fatty acids are administered as a supplement sometimes for the treatment of hyperlipidemia. They are found in fish oil, and consumption of high levels of omega-3 fatty acids is associated with a lower risk of cardiovascular events like myocardial infarction and death. If you look at the bottom of the screen, this is an example of an omega-3 fatty acid. This is the omega end of the fatty acid, and if you go to the third carbon here, there's a double bond, and that's why it's called an omega-3 fatty acid. If you take these as supplements, it will reduce the rate of VLDL production by the liver, and it can lower the triglycerides, and that's mainly what omega-3 fatty acids are used for, the treatment of hypertriglyceridemia. There's also a small increase in the HDL. And there are commercial supplements you can purchase at the pharmacy. One of the most popular ones is called Lovaza, and this will administer a high dose of omega-3 fatty acids in a supplement pill. The side effects are mostly GI, so patients can feel nauseous, they can have diarrhea, and they sometimes complain of a fishy taste. The newest class of drugs for treatment of hyperlipidemia are the PCSK9 inhibitors. They were initially approved for use in 2015 by the FDA. The two main drugs in this class are alirocumab and evolocumab. They are both antibodies. And what they do is inhibit the function of PCSK9. So PCSK9 normally degrades LDL receptors on the surface of hepatocytes in the liver. So when these drugs inactivate PCSK9, there's less degradation of LDL receptors. More LDL receptors are found on hepatocytes, and as a result, more LDL is pulled from the plasma, and there's less LDL cholesterol in the plasma. Because they are antibodies, PCSK9 inhibitors are stored in the refrigerator, and patients have to administer them by subcutaneous injection, usually every 1 to 2 weeks. They result in very significant LDL reductions, even more than statins, as much as 60% in some patients. And the only real adverse effects are injection site skin reactions. Patients can develop irritation or sometimes infection at the site where they inject the drug. The real problem with these drugs is their cost. They're antibodies and they're very, very expensive. So in general, they are reserved for patients who have hyperlipidemia that persists despite statins. This could be a patient with very high LDL levels despite taking statins. We also sometimes use these drugs in patients who are intolerant to statins due to muscle problems. And that concludes our module on hyperlipidemia.